Welcome. Today we will discuss some dermatology. Let's start with melanoma. You know the basics. The ABCD criteria: asymmetry, borders will be irregular, color will be over odd or variegated, diameter more than 6 mm, and evolution, the changing over time. But you have to know the NBME trap here. They will give you a patient with a weird mole. It meets all the criteria. The question will ask what is the most important prognostic factor. You might want to say diameter or lymph node spread. The answer is Breslow depth thickness. This is the vertical thickness of the invasion, and depth dictates survival. Do not confuse this with Clark level. Breslow depth is gold standard for prognosis. So once you suspect melanoma, what's the next best step here? The answer would be excisional biopsy. You remove the entire lesion with a tiny margin 1 to 3 mm just to diagnose it. Do not choose shave biopsy for suspected melanoma. Why? Because you need the full depth for staging. If you shave it, you slice off the bottom and ruin the staging. Do not choose wide local excision as the first step. You diagnose first with a narrow excision, then you go back for wide margins once you know the depth. Once confirmed, how much margin do you take? So for melanoma in situ, you take 0.5 centimeter. For thin one, you take 1 centimeter, and for thick is 2 centimeter margins. So this is how you diagnose. This is how you know the thickness of it. We know the risk factors. Not all sun exposure is created equal. Squamous cell and basal cell, these are linked to cumulative chronic exposures like farmers or sailors. For melanoma, this is kind of linked to intermittent intense blistering sunburns. So think of any office worker who goes to Hawaii once a year and gets fried. That might be a chance to get a melanoma. Sunscreen reduces squamous and basal cell risk definitively. The data for melanoma is less clear, but you still recommend it. Genetics like fair skin, red hair, blue eyes, they have the higher chance to get it. There is a mutation for this. The mutation is BRAF. If they have metastatic melanoma, you check for this mutation. If it's positive, you can treat it with Vemurafenib, which is a BRAF inhibitor. So Vemurafenib is the treatment of choice in this case. For let's say you have a case with well demarcated erythematous plaques with silvery scales. We know this might be psoriasis. Psoriasis comes on extensor surfaces like elbows, knees. Contrast this with eczema, which loves flexor surfaces. So what do you do specifically for psoriasis? You if you scrape the scale and you get pinpoint bleeding, this is called Auspitz sign. And why it is happening? Because the dermal papilla, they are elongated and thin. So bringing blood vessels right to the surface, it will lead to a pinpoint bleeding. Um, you get a trauma and psoriasis plaque form right in that scar line. This is called Koebner phenomena. So these two signs, they are specifically important for psoriasis. We have, if you see neutrophils collecting in the stratum corneum, this is also psoriasis. This is actually, we call it Munro microabscesses. This is a classic feature in psoriasis as well. So it's not just skin. 30% of psoriasis can present as a psoriatic arthritis. So the presentation will be sausage digits, like we call it dactylitis. We have on X-ray you will see pencil and cup deformity. So you look at the nails, you will see nail pitting. These are little depressions, or you can see onycholysis, which is lifting of the nail bed. So if a patient has a joint pain and nail pitting, it is psoriatic arthritis, even if they don't have the skin rash yet. uh, Morning stiffness that improves with the use, this is rheumatoid and psoriatic both. A contrast to other osteoarthritis does not improve with the use. Treatment would be we give methotrexate. This is the drug of choice here because it treats both skin and joints. NSAIDs can help technically, but methotrexate can be used for psoriasis directly um, in some of the medications can trigger psoriasis. Beta blockers are classic. Antimalarials like hydroxychloroquine, ACE inhibitors, and one is lithium. You know about lithium. It's a gold standard for bipolar disorder, but its side effect profile is a board favorite. So a patient with bipolar disorder comes in with worsening silvery rash on their elbows. So they might want you to frame as a new rash. Which medication in the history is responsible? So it would be lithium. Lithium actually interferes with the inositol phosphate 3 pathway, where while that helps stabilize the mood in the skin, it kind of dysregulates your calcium homeostasis in the keratinocytes, leading to hyperproliferation. So we have other side effects of the lithium, like it causes tremors. You treat the tremors with the propranolol. It causes nephrogenic diabetes insipidus. So the patient pees a lot. Why? It directly antagonizes ADH at the collecting duct. So it's one of the reason of nephrogenic diabetes insipidus, and it also causes hypothyroidism. So you have to check the TSH levels too. And we don't give it in pregnancy because it causes Epstein's anomaly, which is atrialization of your right ventricle. And we have the psoriasis flare as well. So if you see a bipolar with the rash, you just treat the rash. We have to look at their whole meds. For say someone gets a strep throat, if a kid gets a strep throat and then erupts in tiny raindrops of psoriasis, that is Guttate psoriasis. Somehow when you stop the systemic steroids, it can cause a massive flare too. So it leads to pustular psoriasis as well. So how do we treat it? Mild cases, topical steroids is the answer. Emollients we can give, or basically we can give vitamin D analogs, calcipotriene. The mechanism of action of vitamin D analog is it actually inhibits your keratinocyte proliferation. For moderate to severe cases, methotrexate can be used, cyclosporin can be used, and UV light can be used. Biologics, these are the big guns. We use it after that. TNF inhibitors like infliximab, adalimumab, they can be used. So before you start a biologic, you must check for TB. You do the PPD or quantiferon, and you have to check the Hep B as well. So this is the summary of these both conditions. That's it for today.